and welcome back to Connecting Citizens to Science. I'm your host, Dr. Kim Ozano, and this is a podcast where we explore global health and development by bringing together researchers, practitioners, and community voices to share insights that can help drive positive change. Before we round off our gender justice series, we're going to take a moment to focus on tuberculosis. This is a topic that's at the front of people's minds this month with the Union World Conference on Lung Health. In this episode, we're going to be looking at what TB really looks like in the UK today. It's a disease that many assume has disappeared, but which continues to affect thousands of people each year. To help us explore this in more detail, we're joined by Kate Bradfield, who is a community TB nursing team leader for North Merseyside at the University Hospitals of Liverpool Group. Kate has been a TB specialist nurse since 2020, and she now leads the service driving quality improvement and community-based support for patients. We are also joined by Amina Farah, who is a program manager for the Latent Tuberculosis Infection Screening Program in Liverpool. Amina has worked in TB since 2016 and brings both professional insight and personal experience as someone whose own family has been affected by the disease. And today they share what's happening on the ground, how stigma continues to shape people's experiences, and what it takes to support patients through long and often challenging but successful treatment journeys. Let's get into it. We've talked about TB on this podcast before in lots of different contexts, but today we're going to talk about TB and the UK. And a lot of people in the UK think that it doesn't really exist in the UK or it's not really a problem, and we want to know more about the reality. So we have some fantastic guests with us today to talk to us about that. So Kate, welcome to the podcast. It's great to have you here with us. Perhaps you could start by describing the TB situation in the UK and globally.
In the UK, since I've been a TB nurse, what we found is our rates in North Mersey have doubled in terms of active TB. And I think that does echo the national picture. And there's lots of reasons for that, one of them being delayed diagnosis following COVID. But I think what's quite good for us is we do have access to healthcare and we do have free treatment for TB and we do have the infrastructure required to deliver that. Although our rates have doubled, they are very low. We are still maintaining that very low incidence recognised rate by the World Health Organization. Globally, it is still the number one killer in infectious diseases. So we still see an estimated number of cases of 10.8 million people being infected with TB. And we still see people dying globally. And there isn't really a reason for it. It should be ended. It shouldn't continue to affect people. But it all comes down to finances, doesn't it? And that's supporting the infrastructure that's required in resource-poor countries.
Thank you very much. So 10.8 million globally. Do you have those numbers for here in the UK?
We are seeing a rise. In 2023, the notifications were 4,831. And then within a year, that went up to 5,490. So it doesn't, you think, oh no, it's only another sort of 600, but it's a lot. And it's a 13% increase, which is significant. So nowhere near the same numbers that you've got in countries where they don't have the same infrastructure and free healthcare. In the UK, we have infectious diseases teams. We've got specialist nurses like myself and Amina that look after people in their own home, and we make sure that they can get through treatment and manage the sometimes very debilitating side effects of the TB medication. And support them with the social costs, like not being able to work and trying to navigate systems of welfare.
I think when the numbers are lower, often cases can get misdiagnosed or the awareness is probably not the same as some of the other diseases here in the UK. Amina, as well as having 10 years experience as a TB nurse, you also have personal experience of this and what it means to have a diagnosis. Could you talk to us a bit about that?
Yeah, sure. A close family member of mine was diagnosed with TB. It was my elderly mother. At the time, she would have been about 74. I didn't work in TB then, I worked in cardiology. Before she was diagnosed with TB, we were back and forth to the GP numerous times because she had a history of a long-standing cough, night sweats, fever, a cough that just wasn't shifting really. And how it happened was she was going to the dentist initially to get her teeth removed for her dentures to be fitted. And obviously she couldn't really eat because her teeth were being removed. And during that time, she just became really tired and developed this cough, couldn't really eat. So we took her to the GP. They prescribed her antibiotics, which helped a little bit at first, but nothing really shifted. During that time, her symptoms became worse, her cough. It was the night sweats that were quite alarming, really. When we say night sweats, it was just drenching night sweats of a night time. So we just go back to the GP and again, different types of antibiotics. Nothing was helping. Symptoms again became worse, the cough, lethargic, the night sweats. But then she became a little bit confused. So she had a chest x-ray eventually, but we didn't get the results for the x-ray because we had to take it into the hospital due to confusion. And we're thinking, what's going on here? I think the GP was looking for a cancer diagnosis, really. So said, it's not cancer. I don't really know what it is, but we're going to look into it. But in the meantime, she did get worse and we took her to the hospital. She was then diagnosed with miliary TB, disseminated TB. So TB kind of everywhere, really, in her body and her brain as well. And that's why she became a little bit confused towards the end. So she was given treatment. She stayed on treatment for about a year. During that time, as she was getting a little bit better, the nurses did come and visit. And that's the reason why I ended up into TB, because we didn't really know about TB as a family, what it was, the signs and symptoms really to look out for. So the nurses were amazing that used to come and see her, used to help her in terms of her moves and minimise that stigma, because Mum was old school and she was quite stoic and she didn't really want anybody to know that it was a TB diagnosis. And she was like, oh no, it's that infectious disease, and can you tell people that it's pneumonia and it's not TB? She was in hospital for a month, I think, and then started to get better and came home. But the take home for me was the late diagnosis, and the nurses were amazing, giving us education, not being scared, relieving my mum of these anxieties because she was quite elderly at the time and she was very poorly. And now, being in TB and understanding she might have been exposed to TB and had latent TB for a long time. And then as she's gone to the dentist to get her teeth out and she's not eating, and her immune system's maybe dropped a little bit, maybe the bacteria might have woken up into active disease. So, so that's why I became a TB nurse and came into TB.
I think that's one of the major things. We still have a delayed diagnosis for people because they aren't referred on to the right services early on, because GPs will rarely come across TB unless you live in a city where there is, in a lot of cases, it's not on your list of differential diagnosis. We still are a low incidence country, a very low incidence country. We still see a lot of delayed diagnosis, and that's because of the delays in primary care. And there isn't a network of awareness raising at the moment.
And as the NHS becomes more pressurised, I can see this will become a harder job. So, Amina, you raised so many things in your story. You talked a little bit about stigma. Maybe you could talk to us a little bit about stigma, but also any gender differences around TB.
Yeah, there is still quite a bit of stigma, really. But again, it's having that lack of education, really, and understand that there is treatment out there and to seek that treatment and take it. It's a long duration, really, to be on treatment for 6 months or a year. And it's hard for people taking tablets every day, but that's our job, really, and that's our role, to support people through that and minimise that stigma and get people through treatment successfully.
The World Health Organization Global Report reported in 2024, 55% of men are affected. What I do find interesting is locally, 66% of our patients are males. So we can see that gender difference is still there no matter what your healthcare system is. It can be much more difficult to screen men for TB than women. So it's trying to adapt to that, really. And I don't think our healthcare system doesn't necessarily meet that person where they're at, because our service is a 9-to-5 service. We can't put our blood tests in after 4 o'clock. So trying to get somebody who is on a 0 hours contract and has a family and children to feed, and their wife can't work because she's got tuberculosis, that can be quite challenging.
And in terms of women, is there anything to raise around women's experience?
What we have to be careful about with women in particular is pregnant women and children,
Small children.
yeah, are very vulnerable when it comes to TB and can have quite poor outcomes.
Could you tell us a bit more about contact tracing and case finding in the UK? Is that something that's active?
If you've got somebody that's been diagnosed with TB and they're worried about, obviously, the stigma, they don't really want to tell people that they've got TB, so they don't really come forward with names of any close contacts within the family household. So we do have to build a really good relationship with our patients to relieve that anxiety and stress.
We do contact tracing of active cases. And then also we're quite lucky here, aren't we? Because we're funded to do screening for latent TB.
It's called the Latent TB programme in Liverpool. And there is a criteria. And the criteria is you have to be between the ages of 16 to 35 and come from a very high incident TB country. The majority of people will say, I haven't got TB. And I said, what we're looking for is the exposure. And then if they have a positive blood test, to offer screening treatment then of antibiotics, and just to minimise the risk of them developing active TB later on in life. It's quite successful.
Yeah, well done. So I'm getting a real picture here in the UK. There's a lot of awareness raising that needs to happen. What really strikes me is this is such a person-centered approach because it has to be. You have to know the patients, you have to know the families, you have to work with them and really navigate any fear or stigma that they might experience, which takes very specific skills. So I can imagine being a TB nurse, you definitely have to have that specific skill set. Is there any other barriers in your role that you face?
You have to wear a mask. That's a pain because you want to smile at someone and you want to make them feel like you care about them. And if you're using an interpreter, that can be quite challenging because you're trying to convey that you do care and you do want to listen to them and understand their situation and meet them where they are. Amina and I have both worked with patients that have got drug-sensitive TB, and we've also worked with patients that have got multi-drug resistancy. And it is truly challenging to take tablets every day for a year, and they have to take lots of tablets when they're multi-drug resistant. And actually, sometimes you just literally have to hold their hand. There's nothing medics can do because they have to take this treatment. They try our best to limit these side effects. But actually, what's really important is just sitting with them.
There's a lot of new findings and I think learning from other countries globally as well that's coming into practice. How has that affected you over the 10 years as you've seen that progress?
I've been working for the team for 5 years, Amina for 10. And in that time, there's always work going on in the background, isn't there? But on the front line, what you're seeing isn't very much. Do you know what I mean? The thing that has happened, though, that is a real game changer for our patients who have multi-drug resistant TB. So that's where we have standard drugs that we use and work really well. But there are drug-resistant strains of TB. So in that case, the regimens have been really complex for all that time. 18 months to 2 years of treatment, very grueling side effects for the patients. But what we have seen is these advances in the 6-month regimes. We've got 2 patients on the 6-month regimens, and the difference that's going to make to their lives, they'll get through this period of their life so much quicker. It's so challenging to sit with someone and say, yeah, you will get through this and you will be cured, but it's not going to be until 2026. You know what I mean? It's or 27 or whatever. So that's been fantastic.
Do you learn from other countries globally? Are there lessons that come from the countries that maybe have higher rates that you're able to apply in practice?
We look into a lot of research and we attend conferences around the UK where people do public speaking and the work that they've done abroad, and then maybe put it in our practices. Fundamentally, I think the message is the same, really, that TB is curable.
So it's come to that time where we wrap up the episode and we'd like our listeners to go away with some key messages. What do you really want to get out there in terms of a TB and your experience?
I think for me, a persistent cough, always seek help. A persistent cough lasting more than 3 to 4 weeks, coughing up blood, unintentional weight loss, severe unintentional weight loss, and severe drenching night sweat. So I think if these signs and symptoms are not shifting, just to keep persevering a little bit and be a bit more persistent.
Thanks very much.
Yeah.
And Kate, what do you want our listeners to take home?
I think for me, anybody could get TB. You know, I mean, Tom Jones and Tina Turner, they can get TB. Anybody can get TB. And I think Amina's right, people understanding what the symptoms are, because often they look like another illness, but it's thinking about your risk factors. What are your risk factors for TB? Have you travelled to a country with a high burden of TB cases? Unfortunately, drug users and alcoholics are at a higher risk of TB. People who have malnutrition, living in poverty, often are disproportionately affected. And I think it's trying to reach those vulnerable groups who may be disproportionately affected to say, just keep knocking on the door of your GP and say, what if it could be TB? So I think it's helping people understand it's not a massive problem in the UK, but it is here. Mm. And the only way to limit cases for that early diagnosis, which will prevent future complications.
So I think the message is very clear. Anyone can get TB. Keep an eye on those symptoms. If you might be in a vulnerable group, or your GP or professional or researcher, keep an eye out for people who might be vulnerable to this. And a real message to knock on the GP's door, mention it, talk about it. There's nothing to be lost by saying, have you tested for TB? So thank you very much for talking us through the episode today and talking us through TB and what it looks like in the UK and globally as well. Thanks to our guest today for a really enlightening episode on TB in the UK. What's really interesting is how the issues that we've heard today have kind of overlapped with the issues we've been hearing about in the Gender Justice miniseries, Backlash, Resistance and the Path to Gender Justice. From stigma and inequality to access and power, they're all part of the same global picture, and we are seeing the same kind of things emerging. We will be continuing with the Gender Justice podcast with the final episode, which we will launch before the Christmas break. And then in the new year, we'll be bringing you more stories and insights from across the global health and development context. So if you're working in this space and have a story, experience, or idea you'd like to share, we really would love to hear from you. You can reach out to the Connecting Citizens to Science production team at the Stop, Collaborate and Listen agency. And of course, make sure you subscribe wherever you get your podcasts so you don't miss what's coming next. And you can find links to the Union World Conference on Lung Health and related TB resources in the show notes, so check those out. And until next time, stay connected.